And next we have Dr. Klemm, who will be talking about alternative and complementary approaches to the care of IBD patients.
Wonderful. Thank you so much. It really is a pleasure to be here today. I'm going to talk about a topic I think many of us shy away from. So I am hoping that by the end of this talk, you'll be able to have more comfortable conversations with your patients where you feel more well-informed of this. So these are my objectives. We're going to discuss the prevalence of CAM, predictors of use, why it's important for us to have a familiarity with CAM, and then I'll also discuss various or the most common types and forms of CAM that are used by our patients and also have data behind them. So what is CAM? Well, CAM is very much this group of very diverse medical and healthcare systems, as well as practices and products that are generally not considered a part of conventional medicine. When we talk about CAM, the complementary part of it means that it's adjunctive or it's concurrent to the use of conventional medicine, whereas alternative is obviously something that's in place of conventional therapy. Integrative medicine is quite popular. This is the use of CAM that's applied by physicians and traditional healthcare providers. And CAM, this really is an umbrella term that includes natural products such as herbs, vitamins, probiotics, as well as many different mind-body practices. So things like yoga, acupuncture, meditation, and chiropractic. The World Health Organization does recognize CAM as a significant component of global healthcare, and so it's really important that we are familiar with this, and there is this attestation of evaluation of its safety and efficacy because of this. I think anecdotally, many of us know that our patients are using CAM, whether they're disclosing it or not, and I think anecdotally, we also feel like more and more patients are using it. And the studies show that anywhere from about 54 up to 90% of patients with IBD are using CAM therapy at some point over the past 5 years. Even pediatric population, anywhere from 22 up to 84% of pediatrics are using this. Obviously, there's probably a great influence from parents and family members on this. And then importantly, for patients with IBD, up to a third of those are actually using CAM specific to their inflammatory bowel disease. So we know, the literature shows that there is increasing use of CAM in our patients with IBD, but is this actually reflected in our current understanding of CAM in the literature and recent publications? And unfortunately, it's not. Between 2000 to 2020, CAM represented only 1% of all publications related to IBD. So you can compare this to the microbiome, which it was almost 7% of publications, or diet related in IBD, which was 6%. And CAM is very difficult to study. So, as I mentioned, there's numerous products and services that are included under this umbrella, which make it very difficult. There's also various challenges with standardization and quality control. We have insufficient preclinical data, and then funding for a lot of these natural occurring products, you can imagine, just isn't going to be there. There are various established and known predictors of CAM use. So female gender, higher income, living in an urban dwelling. Certainly side effects or dissatisfaction with conventional therapies is a predictor of CAM use. And in patients with IBD, prolonged use of steroids, as well as a long-term progression of disease is associated with it. And then also influenced by friends and relatives as well. So why should we know about CAM? I mean, our patients are getting enough information online through Dr. Google or ChatGPT, but there are various important aspects of CAM use that we should be aware of. So firstly is safety. Even though our patients are on CAM, 80 to 87% of them don't actually feel well informed of the therapies that they're taking. And 54 to 74% of these patients aren't actually disclosing it to us. And this is obviously a huge safety concern because we don't know about potential drug interactions and just potential side effects of what they are on. There's also an issue with compliance too, because patients who are on CAM, sometimes there is a covert dose reduction of their conventional therapies when they are taking CAM therapies. And I think many of us have actually seen this in practice. Thirdly, CAM use, one of the issues is related to rapport and the therapeutic relationship. So 65% of our patients who are on CAM do want to discuss it with us. And so there is an opportunity there for us to really build rapport and build that therapeutic relationship. But also CAM use is associated with a dissatisfaction with patient and doctor relationship, as well as poor physician communication. Lastly, it's important for us to know about CAM because it can tell us a little bit about the efficacy of our own medication, our own sort of standard care that we're providing, because many of the symptoms that patients are using CAM to treat are symptoms that we're actually supposed to be treating with our medication. So things like abdominal pain, diarrhea, and fatigue in our IBD patients. So this is a list of some of the most commonly used CAM by patients with IBD. First, I'm going to talk about cannabis. I think it's probably the most important to talk about. This is just a schematic that shows the legalization of cannabis throughout the states. Green shows where it can be used medically, and then orange shows where it's being used or it's legalized for both recreational as well as medical use. So cannabis use is actually quite high in patients with IBD, anywhere from 12 to 37%. It's interesting. It's important to note that 12%, that lower number, was done in a study back in 2013, and that was right after the legalization of cannabis in Colorado and Washington, which were the first states. So if you fast forward now a decade later, we're seeing up to 37% of our IBD patients are actually using cannabis. And 63% of these patients are actually using it for their IBD and their disease symptoms specifically. That jumped up from about 16% back in 2013. So it's quite a large number using it specifically for IBD. And as I mentioned, symptoms that they're using it for: abdominal pain, cramping, and diarrhea. Now, patients who are using cannabis for IBD for symptom relief, unfortunately, they're using it more frequently than those who are not using it for symptom relief. So those that are just using it for recreational purposes. And these patients are also noted to have a significantly higher rate of abdominal surgery, chronic analgesic use, as well as other forms of CAM use. So as most of us know, cannabis contains nearly 500 chemicals, and THC and CBD are the most common. THC providing us with that psychotropic effect or that feeling of a high, whereas CBD is known more for its anti-inflammatory and immunomodulator effects. And the use of cannabis in IBD really relates to our endogenous endocannabinoid system. And this is linked to visceral pain perception, many GI symptoms like nausea, vomiting, gastrointestinal motility, as well as intestinal inflammation. This is a schematic that shows the location of your cannabinoid receptors, CB1 and CB2. You can see that the receptors are located in epithelial cells, intrinsic and extrinsic neurons, as well as vagal affect nerves. And they're also within a subset of our immune cells, so certain T cells, B cells, activated macrophages, and neutrophils as well. There are animal models of colitis that show the specific targets and pathways for endocannabinoids and potentially cannabis. So in these animal models of colitis, CB1 and CB2 are upregulated. And then when they're exposed to endocannabinoids or cannabis, it actually causes a reduction in the severity of colitis in these animals and severity of inflammation. And so getting into sort of clinical data or clinical trials that we have, there is a meta-analysis that looked at Crohn's disease patients who had moderate to severe disease that were either on immunomodulators, steroids, or biologics. And it compared patients taking cannabinoid therapy to placebo. So before the cannabinoid therapy, the clinical or symptom severity scores were the same. And then after therapy in these Crohn's disease patients, those who had taken cannabinoids had actually had improvements in their clinical scores. That same meta-analysis looked at actually endoscopic response and found that there was no difference in Crohn's disease patients after they were taking cannabinoids compared to those that were taking placebo. Now, similarly, this meta-analysis looked at patients with moderate to severe ulcerative colitis and found that there were no improvements in symptoms in those that were taking cannabinoids or exposed to cannabinoids compared to those that were on placebo. And then there were other secondary outcomes that the meta-analysis looked at. So quality of life, interestingly, there was improvement after cannabinoid treatment in both UC and Crohn's disease patients after taking cannabinoids. There was substantial heterogeneity in these studies, however. And then looking at our biomarkers of inflammation, there was no difference in CRP. So there was no difference specifically for Crohn's disease. And in fact, they found that those who were receiving cannabinoids in the UC population had lower CRPs to begin with. And then similarly with fecal calprotectin, there is no benefit in cannabinoids in terms of reduction in this biomarker for both Crohn's disease as well as ulcerative colitis. I think, we're all very well aware that in the general population, there are multiple adverse effects of cannabis, whether that's sleepiness, nausea, poor concentration, confusion, abnormal brain development, progression to use of other drugs. There's quite a long list of potential adverse effects. And then in IBD patients specifically, there are specific adverse events that we need, or adverse effects that we need to be aware of. So for both Crohn's disease and ulcerative colitis, the use of cannabis is associated with an increased ED visits and increased hospitalizations. In Crohn's disease specifically, there's an increased use of steroids as well as opiate use, which I think is quite concerning. So to conclude on cannabis, we can say that yes, there is an association with improved quality of life for patients with both Crohn's disease and UC, and there may be an improvement in symptom severity in patients with Crohn's disease, but not UC. But when it comes to our objective markers, like our biomarkers of CRP, fecal calprotectin, and then endoscopically, we are not seeing any improvements with the use of cannabis. And certainly there are a higher proportion of adverse events specific to our IBD population that we need to be aware of. Next, I'll talk about turmeric, and specifically its bioactive component, curcumin. Turmeric has been used for thousands of years in many sort of traditional and Eastern forms of medicine because it does have reported anti-inflammatory effects. There are animal models that show that TNBS-induced colitis actually improves when given curcumin. And so they find that there's a reduction in the infiltration of CD4 T cells, inhibition of various cytokine modulators, as well as an improvement in histologic inflammation as well. And curcumin itself has been studied in humans, but only in ulcerative colitis. So if someone's coming to you with Crohn's disease, we do not have any data on that. There is a meta-analysis of 6 RTCs that looked at mild to moderate UC patients who were already taking standard of care with mesalamine products, whether that was rectal or oral. And they basically compared curcumin compared to placebo. They did find that there was a statistically significant benefit or effect with the curcumin group in terms of inducing clinical remission. However, when they looked at endoscopic response, they found that there was no difference between the curcumin group and placebo when it came to endoscopic remission. There was a numerical signal for endoscopic response, but it wasn't statistically significant. So we're seeing maybe some improvements in symptoms, but again, not actually in endoscopic activity. One thing to note about all of these studies that were included in the meta-analysis is there was high heterogeneity, and many of them used different doses, anywhere from 450 milligrams up to 3 grams per day. It does seem like anything above 500 milligrams may be associated with clinical response and remission. There were different forms of curcumin that was used. So some used oral. There was one study that used rectal that did show benefit. There was treatment as well with the curcumin. It did seem that the longer you took it, so at least 3 months, was associated with clinical remission and improvement. One of the major problems with any of these studies is blinding. As many of you know, turmeric has that very distinctive yellow color that can also stain. So I think blinding is definitely an issue there. There are no serious adverse events with curcumin, however, and just minor side effects such as some abdominal distension, nausea, abdominal pain, dyspepsia, maybe some hot flashes and hypertension. So those studies were all about inducing remission. There's one very small study that looked at 89 patients who again were on standard care with mesalamine product or sulfasalazine. They received curcumin 2 grams per day, and the clinical activity as well as the endoscopic activity was measured. They did find that compared to placebo at 6 months, there was statistical improvement both in the clinical symptoms or activity index, as well as the endoscopic activity. However, that response was not enduring up to 12 months. So at 12 months, there was no difference from placebo. This brings me to a specific product that has gained a lot of attention over the past couple of years. This is known as CurQD. So it's a combination product of curcumin, 1.5 grams, as well as this Asian herb known as Qing Dai, which I'll get into on the next slide. This was a placebo-controlled randomized control study of just 42 individuals. They had an 8-week induction arm, and then those that had responded were then put into an 8-week maintenance arm following. These were individuals who had moderate to severe ulcerative colitis. They could be on other medications, but they couldn't be on steroids more than 20 milligrams per day. And so in speaking about Qing Dai, so this is a herb that's been used in traditional Chinese medicine for thousands of years. It's reported to have these very anti-inflammatory properties, antipyretic properties. So it is used historically for things like psoriasis. There are some animal colitis models that do demonstrate potential sort of pathways or mechanisms whereby when given this Qing Dai, it does increase the activation of this aryl hydrocarbon receptor that then improves colitis in these animals. So in terms of the study, the primary outcome was actually a co-primary outcome of clinical response plus biochemical response plus endoscopic response. And they found that at 8 weeks, it was actually statistically significant. So the CurQD group did have quite significant improvement with that. They also had secondary outcomes where they saw statistical improvement or benefit in clinical response, clinical remission, as well as endoscopic improvement, but not in fecal calprotectin response. And then in terms of rectal bleeding, there was a significant reduction at 4 weeks compared to placebo with the use of CurQD. So as I mentioned, those individuals that responded in the 8-week induction trial then entered into the 8-week maintenance trial. This was a total of 15 patients. For the maintenance trial, they were just given curcumin, not the Qing Dai. This is based on the experience of the investigators in trying to mitigate or minimize side effects of the Qing Dai, which I'll get into. But they did find that over the 8-week period at week 16, 14 of those 15 patients actually maintained clinical response, and then 11 of them actually maintained clinical remission while on this product. And so there is a potential mechanism by way we may understand sort of these improvements. So as I mentioned, the Qing Dai does help to upregulate this aryl hydrocarbon receptor. And when this receptor is upregulated or activated, then you get an upregulation in your CYP1A1. And so in those patients who were treated with CurQD in the rectal mucosa, they also had an upregulation or significant increase in the amount of CYP1A1. And then those who responded to the CurQD had even more of a response in terms of that upregulation of that enzyme compared to the ones that didn't respond. The study did show that there was comparable safety to placebo. Most common adverse events include headache and elevated liver enzymes. But as I already sort of alluded to, Qing Dai is associated with a very rare development of pulmonary hypertension. And that's why for the maintenance arm, they decided to exclude it. And so to conclude on curcumin, this may be considered as an adjunctive therapy for those with mild to moderate UC who have not had an optimal response to mesalamine products. And it can certainly be considered in patients who are in remission as a supplementary to their mesalamine, but you do need a dose of anywhere from 1 to 3 grams per day. Next, I'll be talking about fish oils. So fish oils are a very common and sort of popular anti-inflammatory. Specifically, it's the omega-3s that we're talking about that have the EPA and DHA in them. Now, the first studies were randomized control studies way back in 2008. And these tested omega-3 specifically against placebo, looking at patients with Crohn's disease and clinical response and remission. And there was absolutely no difference in the rate of relapse. So fish oils were not effective in this study in patients with Crohn's disease and their symptoms. Following this, a few years later, there was a meta-analysis that looked at both Crohn's disease as well as ulcerative colitis. So there were 6 studies with Crohn's disease comparing omega-3s to placebo, and this did actually find that there was a statistically significant reduction in the risk of relapse at 1 year on those with the omega-3s. Excuse me. And then in the 3 UC studies, there was no difference. So very sort of contradictory results that we're getting from these earlier studies. There are various side effects as well to know about fish oils, like an unpleasant taste. You can develop halitosis, heartburn, nausea, and diarrhea. More recently, in 2024, there was the UK Biobank prospective cohort study of a very large number of patients. They saw that those that consumed oily fish, because it's oily fish, it's not non-oily fish that contain higher levels of omega-3s, that if they contained or consumed just 1 serving per week, that this was associated with a 19% lower IBD risk. And then those that were taking a fish oil supplement, this was associated with a 16% lower IBD risk overall. So in terms of fish oils, I think, there is some very promising recent data in a large number of patients, but I think that still there is insufficient evidence to recommend fish oils to reduce the risk of IBD or for IBD treatment. Of course, we have to talk about probiotics when we're talking about IBD. So in terms of Crohn's disease, when we're looking at induction of remission, whether that's clinical remission or endoscopic remission, there's no evidence of benefit with probiotics compared to placebo. And similarly, in Crohn's disease patients for maintenance of remission, there's no benefit clinically in patients who have had or have not had an ICR, an ileocecal resection. And there's also no benefit in those with endoscopic recurrence as well. It is important to note, and again, this is one of the difficulties in studying CAM, is that with all of these studies, they're using different types of probiotic strains, different doses. There's different inclusion criteria, different sort of concurrent treatment that patients on, as well as comparator. And so for ulcerative colitis, there has been a Cochrane review that found that probiotics may induce clinical remission when compared to placebo, but there was no difference in this benefit or efficacy compared to our mainstay of treatment of 5-ASA, and this is a very low certainty of evidence. There was recently a meta-analysis of 45 RCTs. This did show that for induction of remission in UC, that probiotics were favored over placebo. And then it did actually do a subgroup analysis that showed that the addition of probiotics to 5-ASA products may actually be beneficial or provide greater benefit to induce clinical remission for those with mild to moderate UC. And then similarly for the maintenance group, the effect of probiotics was significant compared to the placebo, but this didn't favor the addition of probiotics to 5-ASA was not favored for the maintenance of clinical remission. There's an 8-strain probiotic combination that many of us are aware of. This has been studied for both UC and Crohn's disease. For UC, there is a higher remission rate specifically to this 8-strain, as well as a lower relapse rate. For Crohn's disease, however, there is no benefit for this strain. There's no benefit in inducing remission of active Crohn's disease, preventing relapse of quiescent Crohn's disease, or preventing relapse after surgery. However, probiotics do have benefit in pouchitis. So there is a significantly decreased odds of relapsing pouchitis, and there's also a possible benefit of using probiotics to prevent the initial episode of pouchitis. This is just sort of a really quick slide of other potential herbs that you might encounter in practice that do have some RCTs behind them. So there's andrographis, which is known as king of bitters, is a sort of common term. This has been shown to be superior to placebo in inducing remission and response in ulcerative colitis. There's also boswellia, which is known as frankincense, which has been shown to be as effective as sulfasalazine or 5-ASA in 2 studies for IBD. And then artemisia, which is wormwood. There are 2 studies that show superiority to placebo in inducing remission in Crohn's disease specifically over that first initial part of 2 to 10 weeks. And then aloe vera has also been shown to be superior to placebo, specifically for UC in clinical remission and response. And also acupuncture is actually quite important. This is ranked highest among non-pharmacologic interventions for clinical remission and symptom relief in this recent network meta-analysis, and it shows superiority to oral sulfasalazine. And lastly, this is just a slide I included for resources. ECHO does have a really good guide on the use of CAM therapies in IBD. And there's also various databases where you can look up any type of natural product, herb, or supplement and see if it has any data or research behind it for specific GI conditions or other things. Also important to look to use these too when you're looking at for potential drug-to-drug interactions as well. And that was my last slide. So thank you very much.